Welcome everybody. It's so good to see people that I know and new people that are interested in this topic. And it's so great to be supported in our work by CVS, who is sponsoring this conference, and also two more, one in the Worcester area and one in the Boston area, to get the word out about women and prescription drug use. And I'd like to thank Andrea Martinez-Frey for her belief in the work that we're doing, and I'd like to give her a round of applause. We're also thankful that we have two of our state legislators here who both have been supportive to the work that we're doing around the opioid and benzodiazepine crisis that we have in our area. First is Senator Mike Rodericks, who has been a board member of STAR before he got so busy, but he's still a great supporter, and Representative Paul Schmidt of Westport. Representative Schmidt knows that this crisis knows no bounds, whether it's in a city or in a rural area, more rural like Westport. We have problems everywhere in the state, and I thank these gentlemen for addressing them. And we have two other representatives here, of Representative Alan Silva and Representative Carol Fiola. Thank you for coming today. For those of you who don't know me, my name is Nancy Paul. I am the CEO of STAR and STAR Rhode Island, and I have been working in the field for 41 years. And from very early on, women in addiction has been a concern of mine. When we opened up the detox in 1977, we saw one woman for every 10 men that came in the door. And we know that addiction is an equal opportunity illness, and we had to look at ways to try to get more women into treatment at an earlier stage. We've had some success, but not enough. Many of you know that we run the opioid triage center, and there are 3 of these in the state. And I'm proud that we have the highest rate of women coming in for treatment, but it's still only a third of the people coming in. And I won't be happy until every woman feels safe and non-stigmatized for coming into treatment. So this is a goal that we have, and we have a great group of people working on this with us that are going to be speaking to you today. And you notice that we have 3 women who all excel in the field. The first I want to introduce is Dr. Robin Quinterno. Robin, you want to just raise so? Robin has over 25 years of experience working in the substance abuse field, and she spent the past 23 years of her work specializing with individuals facing opiate use disorders. She currently works as STAR's Director of Outpatient Services and the Clinical Director of STAR's Lifeline Methadone Program. And while doing all this, Robin just recently received her PhD in social work, so I want to give you a round of applause for that. In addition, I should say that she also teaches clinical classes in the School of Social Work at Boston University. The next person who will be speaking today is Susan St. Amour, who, like me, has over 40 years of experience in the nursing field. We stole her from South Coast Emergency Room, where she was dealing with addicted individuals, and she has been at STAR for over 13 years. She's currently our Chief Nursing Officer. Her certifications include, she came to us as a family nurse practitioner, but when she saw the co-occurring disorders of the clients, the mental health needs of the clients, Sue went back while she was working full-time and became a psychiatric mental health clinical nurse specialist. And she is also a certified addiction nurse. So, Sue, thank you so much for coming today. I should also say that Sue has worked very hard with the state on the issues that pregnant women with addiction face, and has helped develop procedures and protocols for that population. Last but not least is Dr. Jeannie Bailey, who is an associate clinical professor of psychiatry and human behavior at Brown University. She's a board-certified psychiatrist with over 30 years of clinical experience. She is a distinguished fellow of the American Psychiatric Association and at the American Board of Addiction Medicine. At STAR, she's the director of our research and director of medication-assisted treatment. And I don't know if people understand how much research has been going on at STAR in the last 8 years or so, 10 years. We have looked at trials for Suboxone injectables, for buprenorphine, depot buprenorphine that lasts for 6 months under the skin. We've seen terrific results with these new methods of delivery. And she has published, and the most recently in the Lancet. So she is a superstar in the research field. We feel very lucky that she is working with our staff in the medication-assisted treatment program. And she comes from Duke Medical School, and she was trained in psychiatry at Yale. It is really an honor to have Dr. Jeannie Bailey with us today. Jeannie? We'll be having 2 speakers, and then we'll have a little break, and then come back for the 3rd speaker. There are ladies' rooms and men's rooms here, but also down the hall. And if you need anything in the front, please feel free to ask our staff who are in the entryway where you came in. So it's my pleasure now to introduce Dr. Robin Quinterno to speak to you.
Sorry, guys, I need Okay. Due to my height challenge, I'm not going to be as animated because I don't want to fall off my assistant. So before we get started, I just wanted to get a sense of who's in the audience. How many people, and you can just raise your hand, how many people are actually social workers? RNs? KDACs? LEDCs? Oh, can you hear me? Sorry. Is that better? Recovery coaches? Pharmacists? Nurse practitioners? Doctors? Very good. Members of the community? Everyone? Clergy? I see in the back. Okay, anyone that I forgot?
Case managers.
Community benefits.
Mass rehabilitation.
Vocational counselors.
All right, well,
PR coordinators.
Prevention educators.
so I missed a lot, apparently. All right, well, good morning and welcome. So today, so basically, let me just put it out and ask what were people kind of hoping to take away from today's presentation? And again, you can just kind of yell it out. All right, expectations are low, I'm there. Excellent, okay. All right, so today I'm going to be discussing the history of opiate use in women. I'm going to be looking at the historical perspective of opiate use in women, current trends of opiate use and dependence, and the societal view of addiction. So, beautiful flowers, aren't they? So, these flowers you're not going to find at the garden shop at Lowe's. you're not going to get for a Valentine's bouquet. Hopefully, you're not going to get this for a bouquet. These are poppies that produce opium. So for a beautiful flower, unfortunately, comes a very ugly result for many people. Overall, addiction is a complex and vexing health and social problem that millions of girls and women battle every day. It's important that we let go of our damaging, often prejudicial and outdated images and ideas about drug users, particularly women drug users, in order to construct new insights about drug using experiences. However, in order to move forward, we must build upon our past. So within the span of a century, the pattern of opiate addiction in the United States has undergone a transformation so profound that it has altered the very way we think and feel about addiction. During the 19th century, the typical opiate user was a middle-aged white woman of middle or upper class status. This generation of addicts were female, outwardly respectable, long-suffering, and thoroughly addicted to morphine. The presence of opium in human civilization was long noted. In 1400s, opium's alternative value was recognized in China when it was transformed from a medicine into a luxury item for its recreational value. This transformation wove opium into the texture of ordinary life, although class determined its respectability. Opium was introduced to the United States in 1827 by the commercial production of morphine by Heinrich Merck, known today as Merck Pharmaceuticals. The preferred way of using opium at this time was in its liquid form, known as laudanum. This was the choice of women, since it could be bought at local apothecaries and through mail order, and most importantly, it was odorless and undetectable. Opium, or morphine used by women at this time, looked to be a substitute for alcohol. Throughout the 19th century, it was considered unseemly for women to drink alcohol. This liquid opium was a powerful temptation, particularly for women in high stations in life, caught up in the social swirl. Also for women stranded in rural areas, thoroughly bored with their lot in life, and seamen's wives that were separated for long periods from their husbands. Around this time, opium dens began to appear, with the introduction of smoking opium, also known as chasing the dragon. These dens could be found in major cities where there were seaports and Chinatowns and where opium imports were accessible. However, these opium dens were the choice of Civil War vets who came back from the war with both physical and emotional ailments and scars. At this time, however, the opium-addicted population in the country consisted mainly of Caucasian women who legally purchased opium-laced cough syrups and elixirs at their local pharmacies. You may never consider giving drugs to small children, and you might certainly never expect to buy illicit drugs at Walmart. Well, not inside Walmart. But in the 18 and 1900s, many women were able to do both of these things with ease. Women's relationships to the medical community, the advertising industry, and consumerism is displayed here in these popular images of women and children found in the advertising of opiate patent medicines, reinforcing particular stereotypes of the nurturing mother who takes care of her family, such as you see here with Mrs. Winslow's soothing syrup, which in the corner you can see it says for teething, for children teething, and it refers to as the mother's friend. What you can't see by this ad is the instructions for dispensing the liquid, which read 3-month-olds 2 drops, 1-year-olds 4 drops, 4-year-olds 6 drops, it gets better, 10-year-olds 25 drops, and adults 30 drops. Yes, so, right, and this resulted in what at the time was looked at as an unidentified high infant mortality rate. Well, but for what we realize today, it was due to overdoses of mother's friend. Also for many women, there was easy accessibility in obtaining laudanum, a tincture of opium by mail, which you see in this advertisement in the corner. 1 ounce bottle cost 8 cents, so pretty economical. Also by mail, you could receive heroin, as we see in the middle, excuse me. So think of this as a 19th century QVC for a woman who has everything, I guess. This choice of substance and its form of access was due in part to male dominance in the social sphere and the perception that it was not right for a decent woman to frequent bars or saloons, let alone opium dens. This increasing interest in the use of these substances sparked a number of surveys from researchers, and from 1878 through 1885, numerous surveys were conducted on opiate use, revealing the rate of addiction at the time, which was nearly triple that of the rate in the mid-1990s. Orville Marshall, one of these researchers, in an 1878 Michigan survey on opium users, indicated that 61.2% of their survey were middle to upper class white women. This disproportionate number of opiate addicts by gender persisted well into the 20th century. This survey also revealed that most individuals that became addicted to morphine did so between the ages of 25 to 45. So prior to 1900, doctors liberally dispensed opium and morphine to their patients, many of whom were female. Male doctors at the time turned to morphine to relieve many female patients' ailments, such as menstrual cramps, asthma, headaches, gastrointestinal diseases, morning sickness, and what they referred to as diseases of a nervous character. So physicians, often with little understanding of drug addiction, inadvertently promoted women's opiate use by making prescriptions available to treat female problems, or what the 19th century medical establishment referred to as hysteria. Overuse often led to physical dependence for these women. Medicinal use of drugs among middle and upper class white women was less controversial, however, both because it lacked the stigma associated with the recreational use and because of the demographic profile of the users. So if used to relieve pain, whether that was real or functional, it was not seen as recreational and did not carry the same stigma. So technology begins to break ground. And in 1853, Dr. Alex Wood of Edinburgh discovers a new technique of administering morphine, injection with a syringe. He finds the effects of morphine on his patients instantaneous and 3 times more potent. So trends continue, and in 1895, Heinrich Drescher, working for the Bayer Company of Elberfeld, Germany, finds that diluting morphine with acetyl, I'm not sure how to actually pronounce that, but produces a drug without the common side effects of morphine. Bayer begins production of diacetylmorphine and coins the name heroin, which is introduced commercially for another 3 years. So heroin at the time was thought to be non-addictive and could also be bought in local apothecaries. So we know that heroin powder, however, proved to be more potent and addictive than the opium-based laudanum drink, which increased the amount of overdoses. And in 1903, heroin addiction rises up to alarming rates. Finally, in 1906, the FDA finally steps in and regulates opium production. But by the end of the century, there were 250,000 addicted individuals. This institutes the Harrison Narcotic Act, which was passed in 1914. This act actually required physicians, pharmacists, and certain other persons who deal with narcotics to register with the U.S. Department of Treasury, pay a nominal tax, and keep a record of the narcotic drugs that they dispense. It categorizes drugs in what we know today as class, so class A, class B. This law also contained a provision that physicians could not dispense narcotics to individuals for the purpose of maintaining their addiction. And this holds true today. So docs can prescribe to known addicts for pain, but they cannot prescribe to maintain their addiction outside of a clinic setting. So it was pretty clear at this point in society that addiction was not viewed as a disease. Roughly from 1895 to 1935, the face of opiate addicts were supplanted by new radically different sorts of users. So it was moving from the middle to upper class white woman to a more lower class urban male, considered down and outs, usually referred to as hustlers. So at this juncture, gone was the stereotype of the addicted matron, and in its place stood that of the street criminal. During the 20s and the 30s, a growing number of physicians came to view addiction as a manifestation of psychopathy or some other form of a twisted personality. This stance helped support mandatory institutionalization of addicts at the time and assisted these docs in refusing the supply of opiates to these individuals. This pardoning attitude was the result of the fact that doctors were exposed to an increasing lower class addict than that of the middle to upper class white woman, who were addicted mostly through medical practice, for which attitudes from the doctors and the laity were generally more tolerant. In 1885, I thought this to be really interesting. In 1885, the British Journal of Psychiatry published a letter said to have been written by a young lady laudanum drinker to her doctor. The letter tells of taking laudanum, a tincture of opium to cure her insomnia, then of her resulting lethargy, desperation for more doses, and horrifying by Victorian standards, her indifference to housework. So, right? I'm not on opium. I don't like housework. Finally, she describes quitting, and she writes, "I don't like owning to bodily suffering, but will not deny that I suffered." She states this before chastising the doctor and his colleagues for allowing this to happen. She goes on to say, "You doctors know all the harm those drugs do, as well as the victims of them, and yet you do precious little to prevent it." So it's a letter, I think, that could have been written about the opioid epidemic of today, driven by a massive overprescription of opioid painkillers that is only now being reined in. The opioid epidemic claims 91 American lives each day, according to the CDC. It's the deadliest drug epidemic in history, thanks to the potency and the type of drugs involved. But the epidemic today parallels the laudanum and morphine overuse outbreak of the late 1800s in many important ways, even sharing some of the same causes and racial disparities, and perhaps offering lessons on how to rein in addiction. So these are the reported overdose deaths from DPH specific to Massachusetts. You can see that there was a 28% increase in 2016 over 2015, with 2,085 confirmed opioid overdoses. However, for all intents, in 2017, there was a 4% decrease from 2016 in these confirmed cases. For the first 6 months in 2018, there were 657 confirmed opioid-related deaths. And DPH estimates that there will be probably an additional 322 to a little less than 400 for the remainder of the year. Among those individuals whose deaths were opioid-related in 2017, where a top screen was available, it showed specific drugs present. So, as you can see, 81% were due to fentanyl, which is not surprising, as we know that fentanyl use is on an increase. 39% was heroin. 19% were prescription opiates. 42% also had cocaine in their system as well as an opiate. And, which I think is pretty significant, over half, 57%, had a benzodiazepine as well as an opiate in their system. Out of these confirmed opioid-related deaths in 2017, we see that 1,160 were men and 431 were women. So men continue to have a higher rate of overdose than women. However, women tend to misuse prescription opiates at a higher rate than men. According to the Drug Abuse Warning Network, or DAWN, which collects data from a nationally representative sample of hospitals throughout the United States, including Alaska and Hawaii, in a 2014 report, they showed that the proportion of emergency department visits involving non-medical use of pharmaceuticals varied by gender. For adults over 18, 50.1% were visits by men, and 55.8% were women. For youth aged 15 to 17, the difference between girls was 45% to boys 31%. So pretty significant. According to Fred Holmquist, the director of Hazelton Launch Program, he states, a drug is a drug, and then there are opioids. Opioids generate a state of mind perhaps parallel only by the highest of spiritual experiences, while simultaneously disallowing any tolerance for even the slightest discomfort. This complicates the patient's ability to remain in treatment or to be available for developing new relationships and acquiring new information. So he speaks to really the power that opioids have over the individual, which had also been recognized by the governor, who in 2015 instituted a task force to address this opioid epidemic. The approach to this epidemic, however, turned from a punitive focus from that of the 19th century to one of a proactive solution focus. And the goals of this objective of this task force were really to reduce opioid misuse and addiction, to decrease opioid overdose deaths, to take actions to address the actual epidemic, and to increase research. So the major key strategies of the task force were for new pathways to treatment. So the state felt that too many individuals seeking treatment utilize ATS or detox as their entry point, even when a less acute level of care may be appropriate. So by creating new entry points to treatment and directing individuals to appropriate levels of care, the Commonwealth would be better able to meet the demand for treatment. This was the impetus to start a opiate triage center. To increase access to MAT, medication-assisted treatment for opioid use disorder is considered the gold standard of treatment and can be a life-saving intervention. To deploy appropriate resources. So the Commonwealth, in partnership with local law enforcement and EMTs, would obtain up-to-date overdose data which could be used to identify hotspots in a timely manner and allocate resources accordingly. To increase naloxone availability, to eliminate insurance barriers by removing a failed first requirement and certain prior auth practices, which would improve access to treatment. To support prevention, education in schools. So we know that early use of drugs increased youth's chances of developing addiction, so by investing in the prevention of youth's first use would be critical to reducing opioid overdose deaths and rates of addiction. Instituting practitioner training, so requiring practitioners to receive training about safe prescribing practices. Implementing PMP, or the Prescription Monitoring Program, by improving the ease of this use of this program and enhancing its capabilities. The disposal of prescription drugs, so reducing access to opioids that are no longer needed for a medical purpose, which would reduce opportunities for misuse. for adults and youth, actually. Acknowledging that punishment is not the appropriate response to substance use disorder, right? So when substance abuse is the underlying focus for criminal behavior, the use of drug courts could be more effective in reducing crime, saving money, and promoting retention and treatment. Reducing stigma. So the stigma associated with substance use disorders is a barrier to individuals seeking treatment and can be life-threatening. And finally, acknowledging that addiction as a chronic medical condition. In 2015, Nora Volkvald, the director of NIDA, the National Institute for Drug Abuse, also identified addiction as a chronic relapsing brain disease characterized by compulsive drug seeking and use despite devastating consequences. I heard someone the other day refer to the disease as an equal opportunity destroyer. And even though the days of it being looked upon as unseemly for women to drink alcohol are long gone, I think women continue to face stigma as a result of their drug use. So I want you all to do a little experiment or exercise. So if you're comfortable, I want everyone to close their eyes. Okay, everyone closed? Okay. So, now, picture a man who's just finished a long day of work. He heads out from the office to play a softball game and goes out to a bar afterward to have a few drinks with his friends. He will close down the bar before finally heading home. What picture of this man comes to mind? Now, with your eyes still closed, visualize a woman ending her workday and meeting with friends for dinner. After this, they head to a local bar, and she too will remain until closing before she goes home for the night. Who is the woman that comes to mind? What does she look like? Now, along with this picture, are there questions of, is she a responsible person? Does she have children? If so, is she a good mother? Okay, you can open your eyes. For most women, these are the many questions that they face in regard to substance use. Even though there's been a bridging of the gap between men and women in recent years, we still think very differently about the two in terms of addiction. Women still have many roles and responsibilities as mothers, as wives, and as partners that they feel they must live up to on a daily basis. The female addict sits in a tremendous amount of guilt and shame and is often afraid to tell even those closest to her the truth about herself. In a 2016 study conducted by Gunn, Sachs, and Jamal on stigma for women with substance use and incarceration histories, they interviewed 30 women and explored how these formerly incarcerated mothers with histories of substance use experienced stigma from their intimate relationships with family and romantic partners. What they found was that nearly 2/3 of the women interviewed reported being stigmatized as bad mothers by their family. Nearly half of these respondents in the study experienced or anticipated stigmatization in their romantic relationships. The authors suggest that, okay, questions until the end. The authors suggest that women may be viewed as more deviant because in addition to violating social norms that prescribe illegal behaviors with a criminal label, their crimes also defy norms about what we consider so-called good women and good mothers. I'll end with a story. In 1919, Willis Butler, a physician in Louisiana, started a morphine maintenance and treatment center. He tells a story of a prominent citizen in the town who walked up to him and denounced his addicted patients as hotheads who should be run into the river. Irritated, Butler took the visitor aside and confided that this man's own 75-year-old mother, an asthma sufferer, who had been addicted for more than 20 years, was a regular patient at the clinic. After his initial shock, the man became the clinic's staunchest supporter. So the theme that I'll leave you with is what we think about addiction very much depends on who is addicted. Thank you.
And some new faces.
We can't hear you.
The mic.
Use the mic.
Or just bend it down.
Hello. Just for those who don't know what my job is, I spend most of my time at STAR on our inpatient unit where people are trying to get off drugs or alcohol. And we do, our census is generally 14 males and 6 females. So there is certainly more males still coming into treatment. And I hadn't really given too much thought to the difference in the prescription drug abuse between the males versus females, except for pregnancy issues. So this, when we started talking about doing this conference, it really made me do a lot of thinking. So I'm going to discuss the pain experience and how it's different between men and women, and then go over some of the reasons for this. And the next part of my discussion is going to be on the class of medications called the benzodiazepines, which are very widely prescribed and they are abused. So this is what we know about men versus women and pain, is that women are more likely to have chronic pain. They're more likely to be prescribed pain medication. They become dependent faster. They're more likely to doctor shop, meaning they'll try out different doctors until they get the medication that they want. And that women do report pain more than men do. So there are some chronic pain syndromes that are very, poorly defined, hard to diagnose, hard to treat, and that are more common with women. And these are some of them are listed here. So fibromyalgia is a very debilitating disease. It's characterized by diffuse pain throughout the body, fatigue, and then there's multiple tender spots along the different muscle groups. And it's seen 90% in females and only 10% in males. Another chronic pain syndrome is irritable bowel syndrome. And with this disease, there's a lot of abdominal pain, cramping, gas, bloating, diarrhea or constipation, or both. And women outnumber men 3-to-1 with this disease. We have temporomandibular joint pain, we call it TMJ, and this is a pain in the joint here that where the jawbone meets the skull bone. And if there's injury or inflammation to the structures in that area, there's a lot of pain, especially with eating. And it's a 2-to-1 ratio, females to males. Interstitial cystitis is a painful condition involving the bladder. And another thing difficult to diagnose and treat. And women outnumber men by 9 to 1.2. Then there's trigeminal neuralgia, which is 3-to-1 ratio for women. And this is a pain, this is the trigeminal nerve, which is the sensory nerve in the face. And this can cause really jabs of sharp pain, even if you're just brushing your teeth or washing your face. And this is a 3-to-1 ratio, women to men. Then there's migraine headache syndrome. It's known to be more common in women. There was a study done by the National Institute of Health that showed the 1-year prevalence rate in females was 18% and 7% for men. And there's the last syndrome I'm going to talk about for chronic pain is chronic pelvic pain. And with this, we're talking about pelvic pain without an identifiable cause, without an injury or childbirth. And they found that this chronic pain in the pelvic area is very frequently happens after intimate partner violence or physical assault or rape. And these things happen in 3 out of 10 women and only 1 out of 10 men. So the chronic pain in females is pretty widespread. So besides experiencing these chronic pain syndromes, we know that women have an increased sensitivity to the perception of pain. They report more severe levels of pain, and they report the pain more frequently and pain for longer duration. So there was a study done through the Stanford hospitals and clinics, and the aim of this study was to look at how pain is reported, women versus men in the reporting of pain. So they found they were able to look at charts of 72,000 patients, and each of the encounters of these patients would have an episode where they rated pain for certain conditions. They were asked to rate the pain on 0 to 10. And they found in the records over 160,000 pain scores. So it was quite a large number of people of scores in the study. And they did find that for every condition, for every condition listed, that the woman's average pain score was higher. And so they had a total of 161,823 total pain scores. 91,003 were females, 70,820 were males. So these were the list of the conditions that they scored. There was a lot of musculoskeletal conditions such as back disorder, arthritis, some joint problems. They also episodes of radiating pain associated with HIV, sinusitis, and hernia. And these were the average pain score for females versus males. And I don't need to read them all, but every single one, the score is higher for females than for males. So there's some other areas of research that are going on that look at the difference in pain between men and women. And this is relatively new. Prior to 1995, which I consider recent, there were very few, if no, studies done that looked at the difference between pain syndrome in men and women. But there are a few things that are going on that I read about that I found interesting. So one of them was the injection of estrogen, which is predominantly a female hormone, and testosterone, which is predominantly a male hormone, into lab animals. So what they did find out was that when the female was given testosterone, that she tended to tolerate the pain better. And when the male was given estrogen, they tolerated the pain worse. And the consideration with this is that estrogen may be sort of like a switch for turning on the ability to recognize pain. Another study that was going on was having volunteers agree to accept a noxious stimuli. So what they did was they applied heat to the forearm of male and female volunteers, not enough to cause tissue damage, but enough to cause discomfort. And then they observed the response on PET scans. So PET scans is an imaging where different areas of the brain light up in response. So they did see a difference in the brain of the male experiencing pain and the female experiencing pain. So those are the things we know, that there are differences, and science is starting to catch up on this. The other way they study response to pain, response to pain is looking at post-op pain. So people that have the same operative procedure, they'll compare male versus female. So those are some of the things going on. I'm going to figure this out. There's new knowledge about pain being different in the sexes. So the other difference between men and women, obviously, is the biological differences. And that's the hormones play a big role, and there's drug metabolism, And then we can't really forget that even though we're a biological creature, things are complicated by the social and psychological environment also. So as far as the hormones are concerned, it seems pretty much that the testosterone has shown to increase opiate pain relief, and estrogen seems to decrease the opiate pain relief. So some ways that this has been demonstrated, just to give examples, is when a woman hits menopause, the difference in pain appears to be less different in postmenopausal women and men than when they are younger, shall we say. However, when the woman is given hormone replacement, some of the pain syndromes have a higher incidence. So if a woman's postmenopausal and then goes on to some hormone replacement therapy, there is an increase in pain syndromes, and they actually found specifically back pain and the temporomandibular joint pain. Another thing we found that leads to the hormone differences is in rheumatoid arthritis patients, that they compared male and females with rheumatoid arthritis, and both sexes were found to have lower androgen levels, which is another male hormone. They were found to have lower androgen levels than their healthy counterparts, and that their symptoms did improve with the administration of androgen. The other medical condition that we see influenced by hormones are migraine headaches. Before puberty, the incidence of migraine headaches is the same in boys and in girls, and after puberty, the incidence in females goes up considerably. We know that oral contraceptives change the frequency of migraines. A woman that go on hormone replacement therapy seem to have more migraines. And even if they're not on hormone therapy, there is variation throughout the month for a woman's hormone levels throughout the menstrual cycle. And we see that there's a higher incidence of migraine headaches in the premenstrual phase of the cycle. And that is about 60% of migraine sufferers have the headaches in that phase. And that there's a certain percentage of women that always get the migraine right during the period. So those are just some examples on how the hormones affect pain syndromes. There's also a thought that estrogen increases the inflammatory response, which is the underlying cause of a lot of pain. So the other physical difference is drug metabolism in males and females. Now, there's actually more information on how the difference in the processing of alcohol and nicotine in men versus women. We know for alcohol that women, their alcohol level rises more with the same amount of alcohol. And we know that they get intoxicated more easily than men. They also develop the medical complications faster. Things like heart disease and cirrhosis, women will develop faster than men, women that drink. As far as the nicotine, women metabolize it faster. So the nicotine replacement doesn't work as well. So these are some of the things that are different about how women metabolize drugs, though. They generally have a lower body weight, which means the level of the medication will be higher in the woman. They have slower GI motility with less gastric acid, so they'll absorb the medication differently than men. And they have a slower filtration through their kidneys, which means they will eliminate the medicine from their body differently. And there's there's a lot of differences in just the way the liver metabolizes medication in men and women. So there's the thought that some of these factors play a part in how women tolerate medication differently. Women are 50 to 75% more likely to experience an adverse drug reaction. The other thing that I found in the literature is that even when they control for body weight, the drug OxyContin is found to have a 25% higher level in a woman's system than in a male's system. The other medications that seem to have a different effect on women than men is a few medications called partial opiate agonists, and there's specifically one called Talin and another one called Stadol. Rather than being full opiate agonists like morphine or oxycodone, they are a partial agonist, but they have a better effect on females than on males, and we're not quite sure why this is. So another difference between men and women is the psychological factors. We know there's a higher incidence of the co-occurring psychiatric disorders in women than in men. And there's higher rates of anxiety and depression among opioid-dependent women seeking treatment. So even though 7 out of 10 drug deaths include opiates, there are other medications that play a role. And that women are more likely than men to die from overdoses on medication for mental health problems. We're going to talk a little bit about anxiety in women. So anxiety is more prevalent in females than in males. And women are twice as likely to be diagnosed with an anxiety disorder than males. Generalized anxiety disorder is twice as common in women. Phobias are 2 to 3 times more common in women. Panic disorder is 2 to 3 times more common in women. And we know there's an association between substance abuse and anxiety. So this brings me to the class of medications called the benzodiazepines. Very popular medication. I don't know how well you can see the picture, but these are 4 of the most commonly used benzodiazepines, and I'll use the trade name because that's what people are most familiar with. There's Xanax, Klonopin, Valium, and Ativan. There's also quite a few others that aren't prescribed as much. There's Librium, another one called Cirax, Restoril, but these are sort of the 4 big guns in the benzodiazepine community. They're widely prescribed for the treatment of anxiety and sleep disorders. They're actually one of the most commonly prescribed psychiatric medications in this country as well as in Europe and Canada. And they do work by increasing a substance in the brain that enhances relaxation. So I do know from experience that they're highly abused. So these are the indications for the benzodiazepines. This short-term relief of acute stress reaction, short-term use in sleep problems. They're sometimes used as seizure prevention, pre-op sedation, and they're a good muscle relaxant. And also, how could I leave it off? They're used to help with alcohol withdrawal. So they were actually discovered in about 1955 or so and introduced for use in the early 1960s. We have the first one was Librium that came out in 1960, and then Valium came out in 1963. They were considered to have a good safety profile more dangerous barbiturates that were a frequent cause of overdoses. They quickly became one of the most frequently used classes of drugs in the treatment of anxiety. However, there were reports within 10 years that there was a potential for addiction, abuse, and withdrawal. One verse is enough. So. How many people are familiar with that song? When I was playing it yesterday, Ramon here and Crystal hadn't heard it, and I realized, oh yeah, it's pretty old. So this song sort of popularized the benzodiazepines. It came out, it's by the Rolling Stones. It came out in 1966. Just like 3 years after the introduction of Valium. And just to go over the words, mother needs something today to calm her down. And though she's not really ill, there's a little yellow pill. She goes running for the shelter of mother's little helper, and it helps her on her way to get through a busy day. So the little yellow pill, I'm assuming it's Valium, 5 milligrams. And this sort of insinuated that they were being used just for their coping skills, rather, as a coping mechanism and not as a treatment of a disease. So I just thought that was interesting. So this is just a brief summary of recommended anxiety treatments. So the actual recommendation is a class of medications called the selective serotonin reuptake inhibitors, known as SSRIs, and that's medications like Prozac, Zoloft, Celexa, in combination with a therapy called cognitive behavioral therapy, or CBT. Now, the SSRIs take a long time to take effect. So they don't have an effect on the body until about 2 to 4 weeks, and they don't really have a therapeutic effect for 8 weeks. So if someone's anxiety is pretty severe or disabling, there's a recommendation to give them a benzodiazepine for the first 4 to 8 weeks, and then to gradually taper it down. The benzodiazepines work fast, and there's no doubt that they do work well. But despite these recommendations, the benzodiazepines are frequently prescribed alone. So this is a study that was done to look, they were looking at prescribing patterns of the benzodiazepines. And it was done through a thing called LifeLink LRX prescription database. It's a prescription database that includes about 60% of all the retail pharmacies in the United States. And they looked at all the benzodiazepine prescriptions for adults aged 18 to 80 during the year 2008. So their database found, they found 46.9 million prescriptions, and they translated it to the whole, on a whole national level to be about 75 million prescriptions annually. It did show that the 2 times more prevalent in women than in men, and that the long-term use increases with an older age. As age went up, so did the long-term prescriptions versus the short-term prescriptions. And this surprised me the most. The highest rate of long-term use was an 80-year-old woman. This is a graph that shows this is the percent of prescriptions, and this is the age. This is men, and this is women. So see how the prescriptions to women really outnumber the male ones. So this doctor or nurse practitioner is saying, nonsense, as long as you take it every day on schedule, you won't have to worry about addiction. And I labeled this slide informed consent because I do think that is an issue that people are prescribed benzodiazepines. They really like the benzodiazepines, but it's not an informed decision, that they are not informed about the consequences and the potential for withdrawal. I mean, I did see this when I worked in primary care. It often caused problems. So I do want to go over some of the long-term effects of benzodiazepine use. So tolerance develops, which means to get the same effect, the person will need a higher dose. They'll have rebound symptoms. So if they stop taking it, the original anxiety returns, but it's even at a higher level because it's been suppressed, so it sort of bounces back up. There's different degrees of cognitive impairment, including memory loss, attention problems, concentration problems. There's some psychomotor impairment, and this involves the general motor function, fine motor coordination, general coordination, speech, reaction time. So this can result in motor vehicle accidents, and it can result in falls. So especially in the elderly, there's an increased risk of falling, and along with falling in the elderly is hip fractures. Yeah, 80-year-old woman were the highest users of the benzos. It does cause sedation, and it causes an exacerbation or a flare-up of chronic respiratory disease. And there was a Canadian study that showed this, that benzo use was associated with a significant risk of adverse outcomes in older adults with chronic obstructive pulmonary disease. They found that new users of the benzodiazepines were 45% more likely to have a flare-up and 92% more likely to visit the emergency department. There's also a possibility of an increase in Alzheimer's risk, and this was from a study in Great Britain where they looked at adults with Alzheimer's just compared to healthy adults, and they did find an increased risk for those that had used benzodiazepines within the past 3 months. So it's not a possible, it's pretty much guaranteed effect that there's withdrawal from benzodiazepines. And this is something that I see a lot in the inpatient unit. So benzodiazepine withdrawal it's varying degrees of severity, and it depends on a lot of things. It depends on the amount of benzodiazepine they're using, and how often they're using it, and how long they've used it. Also, if they've had a withdrawal symptom in the past. Some people will say, well, I was using them for 2 months, but then you find that they might have had a month without them, but in the past they used a lot and had bad withdrawal symptoms. Even though 2 months is a relatively short period of time, they'll probably have a withdrawal symptom, a withdrawal syndrome. It's important to know if they have on a medical or psychiatric problem, if there's any kind of, less than stable medical or psychiatric problem going on, it's not a good time to detox someone off benzodiazepines. They can destabilize easily. Also important to know if they are using other medications with the benzodiazepines, especially anti-seizure medicines, and if they've actually had seizures in the past. And to go over some of the benzodiazepine withdrawal symptoms, and these occur in varying degrees. Pretty much anxiety is always going to happen. They become very agitated, and they have a sleep disturbance. That's one of the first things we find when we think someone might be in benzo withdrawal. We'll ask them if their sleep was different the night before. Sleep disturbances can also go on for months or even years when someone stops taking a benzodiazepine, especially if they were taking high doses. In the acute phase, they'll have elevated blood pressure, heart rate, and they'll have tremors very similar to with alcohol withdrawal. They're hypersensitive to sound, to light, to touch. And one common thing is they'll say they feel like they want to crawl out of their skin. That's pretty common with the benzo withdrawal. Headache is common, some nightmares. Seizures is what we really try to prevent. And then some of these other symptoms listed, the severe psychiatric, the psychosis, catatonia, delusions, delirium. We don't really see that much, at least in my setting. I would suspect that people that go to an emergency department with maybe, say, a psychosis could have an unrecognized benzo withdrawal going on. The paranoia, we do tend to see that. They get a little bit paranoid. You'll see a little bit of change in their affect, and they have that suspicious look going on. So I will tell one benzo withdrawal story because it was pretty much the most severe that we had, but it wasn't a man. It wasn't a woman, it was a man, but I'll tell it anyway. He was taking large amounts of benzos and also pain medication, and he had to come inpatient and get off of those medications because he was going to have surgery. He had a bad hip. He walked with a cane. We saw him getting more and more agitated, and he had that paranoid look about him, looking back and forth. And we did increase his medication, but it wasn't helping. We're keeping an eye on him, and then all of a sudden, when the other patients left the room, he was in our big group room, he took his cane and started banging out the window, and he jumped out the window on the second story. And we feel that was all due to the benzo withdrawal. Luckily, he survived and had his surgery. There was staff chasing him up the street. So that was the most severe case that I've seen. I did see a young woman go into a catatonic state that had been in benzo withdrawal, and she was transferred to another hospital, so I don't know if it was determined that was actually the cause. So our addicts will tell that they hate being in opiate withdrawal. They say, they feel like they're going to die, they're sick, they hurt, they sweat, they hate it. But they'll say, the same people will say, the benzo withdrawal is worse. So, to wrap up, how can women protect themselves from prescription drug abuse? So discuss all medications, including over-the-counter, with your healthcare provider. Use prescriptions only as directed and store them in a secure place. Dispose of medications properly as soon as the course of treatment is completed. Don't keep them around for a just-in-case later. And probably most people away, you can take your medications to our police department to be disposed of. Prevent misuse and abuse by not selling or sharing. And discuss pregnancy plans with your provider before taking medication. And most importantly, get treatment when you need treatment. So that's all I have to say. say. There is time for questions.
Crystal. So you talked about short-term prescriptions with benzos. Is there any indication for long-term prescription?
The question was, is there any indication for long-term prescriptions for benzodiazepines? Yes, there is. The short answer. I believe there are people that have the severe anxiety, severe trauma history, that nothing else seems to work. The other thing is that there are people we see that have been prescribed them for years, that it's almost pretty much impossible to get someone off that's been taking them for years. What I feel is important when this is done is that informed consent piece, that they know what they're taking and what the consequences are. No other questions? I believe it's time for us to take. Oh, I'm sorry.
I was wondering about that long-term use of the 80-year-old females.
Yes.
Why do you think they are the highest users of benzos? Do you have any idea?
What I want to say is 80-year-old men, but Dr. Lee has an answer.
Very commonly, Ativan is used in nursing homes for elderly, not necessarily the best drug of choice, but very commonly it's used in nursing homes for agitation, sleep, sometimes as a co-administration for dementia and the agitation, which probably explains it's not that they're asking for it, but they are prescribed given their age.
I would have thought sleep, and there's just so many reasons for an 80-year-old woman to, with a hell of pain. There's so many reasons to be anxious, but
Or they've been on it for 20 years?
they've been on it for 20 years.
Thank you very much.
Okay, thank you very much, and we can take a break.
Yes, so the last segment, and then you'll be out of here, is going to focus a little bit more specifically on the treatment and what we know about the treatment of men versus women, but then we'll have to just sort of revert to what we know about treatment, because much of the research and much of the data isn't separated out by sex or gender, and actually when we looked, we found limited differences. So that's my introduction. You've seen that place before. Those of you that don't know it, that's an overview of STAR. That's our medical home. And across the parking lot would be you could walk straight out, would be in our detox unit, where we have our step-down detox and other administrative functions. So I always start with my disclosures, which I do work for several of the small pharmaceutical companies, all of which are trying to develop treatments for opioid use disorder. We're going to talk a little bit about some of the general patterns and a little knowledge about retention, outcomes, and then speak specifically about medication for addiction treatments and what we know about the research. So in general, just to start off with, there's a survey that's done every year that starts at the age 12 up through, as long as they will fill out the surveys, that the government does every year. And if you look back at the most recent one we had data for was 2016, 8.8% of the adolescents in both genders reported past illicit drug use. And what's interesting about that is that the parity, that those were all adolescents, but the gender parity really was brought out by adolescent girls who were using prescription opioids. So we're seeing that these prescriptions are finding their ways into medicine cabinets, and the girls tend to be a little more experimental than the boys with this. We also know that if you move into the adult population, the use of illicit substances that were prescription drugs when you look at heroin, it's increased drastically in both genders. What's interesting about the heroin is it's increasing at a much greater speed in women, with about 100% increase versus a 50% increase in the years 2002 to 2013. So women are using, girls are using more prescription drugs, women are using drugs equal to men at this point, and they are now using heroin more frequently. So once a woman gets impaired or gets addicted, we also know that there tends to be a greater impairment, meaning that if you actually monitor how the substance abuse disorder affects her life, you find that there's a more severe impairment and functional impairment in multiple domains, not only in employment and family, but psychiatric functioning. And when rated by them as well as researchers, they have a poorer overall quality of life, meaning that whatever's going on in the addicted body seems to have a greater impact on the woman or on her ability to function. So the one area where that's not true, however, is legal problems. We tend to still see fewer women who have legal issues with their substance abuse. What happens to people and have substance abuse, and what does it do as far as, I would call that last slide our morbidity slide. This would be our mortality slide. How many people or what kinds of people, what do we know about the people that actually die from this? Well, we know that women have had a rate of increase of overdose deaths much more rapidly than men, and that was data, that gap has been closing. That was data from 2013, and it continues to be so. And prescription opioid overdoses among women have increased 400%. 400% in the years of 1999 to 2013. So we see an escalating number of people dying, and when you look at those people just getting treatment, and that we find that these age-matched population estimates that women are doing a 5-fold mortality rate in general from all substance abuses. So they're dying more quickly. Why are they dying more from substance abuse disorders, we don't know. The first one was specifically prescription opioid abuse. So, who comes into treatment? Is there a difference in who enters treatment and how they actually experience or are retained in treatment? When you look at the data, you see that there's a lot of controversy actually, because back in 2007, if you looked at, there was a large study that looked at women and felt that they were seeking treatment less often, and that there were barriers that were unique to women that made it so that women would not seek treatment. However, 2 or 3 large studies since then have shown that there's no difference in when men and women and in respect to seeking and being retained in treatment. So there's past utilization over the last year. Another study found that there were no gender differences in the treatment entry for prescription opioid use disorder. So we know that from the previous slides, women are using prescription opioids more, but they also, so a smaller fraction of them are getting into treatment. But the treatment entry is the same for men versus women. And the other thing is that women are presenting for treatment primarily for opioid use disorder at a higher rate, and this just sort of confirms that it's equal. It's very close to equal. So both studies sort of dispel this idea that women are not entering treatment as rapidly as men. But what we do know is looking at once they get there, there's really no big difference between who stays in treatment, which is news, because we used to think that women didn't show up, and we know now, we still know that they're not coming as often as men if you look at who's enrolled, but that you have to look at the whole population of who's got the disease. So more women are coming into treatment, but more women are having the disease that are staying out of treatment as well. But once you get an individual into treatment, it looks like they pretty much stay in treatment with about the same level of treatment retention. And both of this are data from very, very large studies. This was 24 different clinical trials, had over 11,000 people, and another set of analysis that looked at 1 million substance abuse treatment episodes. So these are large numbers. And they're finding that women stay in as long as men, with the exception of women being unable to complete the detoxification as often. Why that is, we don't know. as well as childcare responsibilities, not being able to sort of extricate themselves to get into treatment. And historically, the only way you got into treatment was through a detox. So I think that's also part of this. Is they couldn't leave their children to be away for 5 to 7 days. And there's not a lot of family support for women going public with what they had. However, we have 2 recent very big population-based studies that say that there's really very few gender differences, and the barriers are there for everybody. And we don't find that they're any greater for women these days than there are for men. And that when you look at large studies, that belief sort of falls away, with the exception of the notion that women, as we learned from Sue, women have a higher co-occurring, that women are much more likely to have co-occurring diseases like depression and anxiety, and there are woeful few, extremely limited treatments for those conditions. So in that regard, because they have a higher presence of women in that population, that is going to be a barrier, and there are going to be fewer women getting treatment for those co-occurring disorders. So do they respond differently once you get them there? Is there a difference in the way our treatment impacts a woman versus a man? Well, actually, we've had some studies that have shown that there's really no big difference in the way a woman will engage with buprenorphine or methadone. I don't find that I have to use a different dosing. I don't find I have to do a different recipe for a woman versus a man, and the data sort of substantiates that, and that's from recent 2013. When you look at behavioral treatments, when you look at CBT and contingency management, some of the other big studies have shown that actually women and men respond pretty much the same. You're going to get the same response rate. It's not going to be high, it's not going to be great, but there's no significant difference in the way women engage in these treatments, be it biologically driven by medicine or by treatment. And in fact, in 2008, it was published that they actually respond almost identically to mutual help groups like AA and NA. That one kind of surprised me, because if I'm going to have an individual who doesn't like AA or NA, it's most often a woman, but that's just my experience. So it made me think that I needed to be a little bit more open to this, because the data would support that the mutual help is available and effective. It's at least the response rates are mutual for both. So, I've pretty much said that other than not being able to complete detox and having higher co-occurring disorders, there's not a lot of difference in the way men and women interact with treatment. Well, that was really sort of confounded, because most people, when you look at animal studies, when you look at rodents and animal studies, the male rats respond differently than the female rats. And that's some of what Sue was talking about with pain. So we have a lot of biological information that would make us think that there should be differences, and that we maybe we're just not smart enough to find it yet. Maybe we haven't asked the right questions. But the other thing is, maybe we're different than animals. And maybe more of the social, cultural, and environment factors have more to do with the development of addiction than we thought once to be the case. So that some of as women's traditional roles fall away and people are living their lives in different ways, women are getting addicted just as rapidly as men, or more in the same patterns as men had previously. So is it the nature or the nurture? We still don't know, but the differences are not as vast as we'd like to think. This slide is one that hopefully you have seen. It's sort of the reason we're here. We're going to shift in and talk a little bit now about just sort of opioid use disorder, primarily the treatment of that. And when there's a difference, I'll try to impose that on you and repeat it, but there's not going to be a lot of difference between men and women in the next section. But the real issue is that people are dying, and if you look at this, this is from 1999 up through 2016, and this is labeling what these overdose deaths contain. And you can see that heroin is on an up. This red line is the synthetic opioids. That's going going to be the fentanyl, and these are our natural semi-synthetic opioids, which is a lot of the pharmaceuticals. But if you look, that's really the reason that CVS is willing to help pay for this. That's the reason we're all working day and night, is because these numbers are rising at a startling amount. And these are not overdoses, but overdose deaths. How are people getting themselves addicted? Well, unfortunately, this graph shows us that people are actually getting addicted, really initially, by heroin, much more than we thought. In 2005, you were much more likely to find your way into addiction using oxycodone or hydrocodone, and not heroin. And other prescription opioids are still lingering and going up. These are much more potent, but we're finding that the heroin is much more leading people into addiction, and the role of the mixtures of fentanyl with that and making it more addicting is undetermined, and we don't know, but it's chilling. Because we all know that with heroin, we have not only the fentanyl, which is leading to the deaths, but we have much more IV use. And with IV use, we have much more needles and the risk of all of the transmitted diseases that are, debilitating for everyone, society as well as the individual. So, very few people, well, I'm going to say when we look at the people that come into treatment for us at STAR, we do have we have a small population of people that remain nasal users of heroin, but not many, because it's a lot cheaper, as you know, and it's a lot more potent, and people rapidly find themselves going into IV use. I was with a young woman the other day who's 26, and she's been using needles since she's 19, and she doesn't have Hep C, and I said, how in the world? That's unheard of. In this city, people convert by 4 months after they start injecting. And she said, I never let anyone use my needles, and I always use a clean needle. And so she wasn't a nursing student, but somehow she wasn't going to medical school or NP, but somebody had gotten to her with some good education about the way that she could protect herself, and she had been successful at it. But the rise in heroin on the road to addiction is a concern. Why are people getting addicted? We're going to shift a little bit about why we think it's a brain disease. Behind and underneath all of these addictions is a brain chemical called dopamine. Hopefully you're in the field, hopefully you've heard of it before. This graph I like, though, because it sort of lets you know a little bit about why certain things are harder to overcome and why certain things are more addicting. So if you look, this is your baseline dopamine of roughly 100. If you have a good piece of chocolate cake, you might bounce up to 150, and if you have a good experience with sex, you might hit 200. But if you are using cocaine, it's going to be twice that almost. So cocaine's better than good sex. And if you go to prescription opioids, it's much better. But the reason we're here is because prescription opioids is 5 times your normal baseline response. And if you inject yourself with heroin or you use heroin, it's really double that almost. This is methamphetamine, and luckily, at least on the East Coast, we haven't seen that much of it yet, but when you see it, you know it, and it's really very addicting, and that's the reason why. But many of the studies that we're finding now talk about the differences in heroin addicts and prescription opioid abusers, with outcome data that's different, with medication responses that are different. And I think this is really part of why. We have permanent brain changes, or not permanent, excuse me. We have significant brain changes that come about when people begin to use substances that alter these dopamine levels and require certain levels in order to have pleasure and responses. And we know that that's the underlying tenet of the idea that addiction is a brain disease. And we say that it's a brain disease because when we look at how the brain, and these are sort of the areas that are going to be high in these dopamine-filled receptors, that we find that we have the reward and motivation center that's buried here in the brain that responds very quickly to dopamine, and that's where those first bursts are going to show up when you're using heroin or cocaine. And that's a reward. You feel it, you're gratified by it, you want to seek it. It's what makes you want to go back and have that second and third piece of cake. And if you're an addict or addicted to a substance, it's what makes you want to originally go back and have more. We find that there are changes in the part of the brain that have to do with conditioned learning and memory. The addicted brain disconnects its ability to remember the bad things that happen and remember only the good things. And that's part of why an addicted individual will override what they know about the consequence. They know they're going to get arrested. They might know that they're going to feel terrible after they do it. They might know that they're shooting into an abscess and it's not going to be a very effective way to get drugs. But they sort of have forgotten about that. It's not connected. And it's part of why people constantly in treatment, I keep telling people, you have to connect the dots. You have to have the addicted individual say these things out loud to you and then say it back to them so that they can hear it, because they need to hear it 2 or 3 times, and somebody has to connect the dots. And it's because this part of the brain is no longer working for them, and they're no longer aware of what's happening. The other part of the brain that is completely disconnected, it seems to us, is the executive functioning or decision-making part of the brain. I say that's often sort of the place where the frontal lobes, where you have the ability to stop, think, well, am I going to go through this yellow light, or am I going to wait and let it be a stoplight? Am I going to say what I think right now because I'm really pissed off, pardon my French, or am I going to step back and wait? Am I going to send that email now, or am I going to wait? Those are all sort of examples of executive functioning, which the addicted brain no longer has access to. So they're much more likely to not remember the consequence, need only the gratification, and go for it. And that's why we say that if you really do scans of the brain, you can see that a brain of the addicted person is significantly different. It looks different on the scans. That's why we say, it's not just choice that's gotten the person here. Maybe originally they made some bad choices, but once they have these pathways altered, the ability to make choice is no longer available to them in the same way it is to you and me. So this is just a scan that sort of highlights that for you. This is a normal PET scan. These are the normal highlighted, activated areas. These are scans of individuals who have been sober from cocaine for only a week. But look at how limited the network is. Look how few of those lighted up, engaged areas are available to them. I try to get my patients to think about the ideas that your brain cells have to touch each other. They send out little fingers and they touch each other. When you're using drugs, you're sort of burning those fingertips. And it takes a long time for them to regenerate and to grow back. And this bottom row is showing improvement, but that's 3 months later. So that's part of why all these symptoms of some of the withdrawal phenomena exist longer than 7 days. It's why many of the problems with addiction and the need to relapse to it exist more than 7 days. And that we don't really know, we can scan this, but we don't really know at a cellular level, when is all this going to normalize and get back, or how and when will it look like that? So we know that our big goal is to try to impact that disease. It's to try to make a difference and keep people alive, and with the idea that the longer you have with them sitting in front of you and the more dots you connect, the more likely it is that they're going to be able to gain back the capacity to do that for themselves. And one of the things I love showing this slide, because this is work from Baltimore that sort of like, when I saw this, it sort of crystallized for me. This is Boston, Baltimore had a high overdose death rate, and this is 1995. So you're seeing that people are dying, and this is your methadone beds. So they were struggling to try to get more methadone slots, but this curve wasn't bothering people that much until much around the late 1990s. But then also buprenorphine got introduced, and once people could get waivered and started treating individuals, looked like people in France for 10 years. 10 years. It was the cohort of 713 people and followed them. And in France, the buprenorphine is prescribed by the primary care doctors as well as pharmacies. So they have very, or is it just pharmacy? So they have very good records of when people are in treatment and when they're out of treatment. I think it's just based on a model where they have to actually go there daily to get it. But they have a lot of good data. And what they showed was that people who have substance abuse disorders are much more likely to be dead at the end of 10 years. And that's about 3 times more likely to be dead per 100 people than the regular population. But more importantly, they also found that when they were in treatment versus out of treatment made a major difference. And if they were out of treatment, it was a 10-fold higher rate of death than it was when they were engaged in treatment. Meaning that buprenorphine was protective. And when you dropped out of treatment, your rate of death and mortality went up significantly over a 10-year history. So, this is just another slide to bring home the issue that medications save people's lives. This line here is this is what it calls a hazard ratio, but basically it's the survival, the rate of being, when you started out with 0.0, everybody was alive. And this moves over years from injection. And if you look, if the person receives no agonist treatment, this is the line, and the drop-off is, you're going to see that many people are dying by 20 years. And these are years of treatment. So if you add back 1 year of treatment, you made a difference. If you keep people in treatment from 1 to 5, you increased it that much. But if you give people more than 5 years of treatment, you really have made a major difference in their survival rate. So agonist treatment works. And that primarily, in this slide, was data that looked at, this was data that looked at basically methadone, because it was before we had a lot of buprenorphine data. So what are these medications that I'm raving about? And I actually don't call it medication-assisted treatment anymore. I call it medication for addiction treatment, because I think the medications are the treatment at this point in time. With the high-potency heroin and high-potency opiates we see on the street, we need to put people on medication and then do our behavioral pieces with them when we get those frontal lobes able to think and calm down. So I, along with most people in the field, have shifted what we actually say because words do matter. And we try to say that this is medication for addiction treatment. FDA has given us 3 alternatives. We have 3 things that we can use, and we're going to spend a few minutes looking at those. Methadone is the one that's been around the longest, and it's what we're calling a full agonist. An agonist is something that makes the receptor do what it wants to do. So if you're sitting in a mu receptor, which is the part of the brain where these things work, we'll give you a little science, whether you like it or not. So if you're sitting in a mu receptor and you want it to do what you want it to do, you stimulate that receptor with an agonist. If you want to block activity of that, you put an antagonist, and that's your naltrexone, naloxone, and Vivitrol. So in between, we have something called a partial agonist, which is an example of buprenorphine. That's a drug where it sort of sits on the mu receptor and it sort of doesn't. It's sort of a partial. It may have other activities, but the point is that when you sit on it, it's with less potent activity. The reason that's important is that's the reason why you hit a ceiling with buprenorphine. The more buprenorphine you take, at some point your brain doesn't have a seat for that much more of it, and it levels out, and that's why it's so hard to sort of die of a respiratory overdose from buprenorphine. And I say buprenorphine, I mean Suboxone. I'm also trying to train you to not think about it as Suboxone, because that's the name of a drug that was put out by a company, and every time we say it, we're advertising it. Just like Kleenex is a tissue. Right? I don't want to advertise Indivior. I want people to know that the medication is called buprenorphine, and that there are many different kinds of buprenorphine that we're going to talk about. But when it's in your brain, you're not going to die of a respiratory stop breathing and die. That's not going to be the same thing with buprenorphine because it's partial and it levels off. And if you throw in an antagonist like naltrexone or Narcan, you knock all the opiates off and you block the receptor. So you sat on it and you said, nobody else can get here and I'm not going to be active. So those are sort of the differences, and that's the strategy behind these medications. Methadone has been around longer. It's dosed only in a particular OTC or in a methadone clinic. That's a federal law. If you're treating opioid use disorder, the Harrison Act says I cannot give people methadone for opiate addiction in my office. So it has to happen in a structured clinic. People have to go every day originally. If they do well, they can get extended take-homes. Those things are kind of very well organized and predicted, and are they federally regulated, like when you can give a take-home? That's what I thought. So it really works much better for individuals who still need a lot of structure. Now there's a stigma about it. People hate going every day. There is some risk that as you get at high doses, you might have cardiac involvement. And methadone has a lot of things that it interacts with. So there's some downsides to it, but it certainly has saved lives, as we've seen earlier. Buprenorphine, the dose range usually is, when done well, the dose range is 4 to 32 at max. I don't think we have anybody on 32. I would say the dose is 4 to 24, but in Europe, 32 is used quite a bit. So it, as I said, is safer because it's not the full agonist. You can give it in an office setting, meaning a doctor or a nurse practitioner now with a special kind of training can give it in their office. That's why it's called office-based opioid treatment, OBOT. And therefore, it supposedly gives us more access to treaters and gives patients more access to getting medication. They have to take it every day, but they don't have to be observed like they do in methadone. People like to sell it or divert it. And sometimes they like bridging it on and off and going off on weekends, going back on a Monday. And with a daily ingestion that they have to do themselves, it's a problem. We do have situations where children can ingest the medication, and at times it limits our ability with pain management. But at the same time, buprenorphine itself can be a treatment for pain. So it has some downsides we'll look at further. The antagonist treatment is basically the depot or the injectable form of naltrexone. It's 380 milligrams, called Vivitrol, and it has no addictive potential whatsoever. And it's really an option, real important option for people who don't want to be on any opiates. It's hard to get onto though because you have to be opioid free, meaning you have to be away from your drug of choice for anywhere from 7 to 14 days, depending on the half-life or depending on how long your drug of choice has stays in your system. And that's all determined by short-acting versus long-acting, which I'm sure you've heard of. So we're finding that it's a big hurdle and to get people to be able to be off the opiate and not relapse, except in structured settings like a detox unit or step-down unit. So it's hard to do. There is some worry that people are more, they're more at risk for overdose when they come off the treatment, meaning that their receptors are completely tolerant-free. And I'm sure most of you gave some indication that you worked in the field. For the people in the community, the whole idea is that when you have been away from your drug of choice for an extended period of time, your receptors become what we call naive again. Your brain becomes naive to the opiate, and if you go back to your former dose, you can die. You can overdose very quickly. People theoretically say that Vivitrol puts you at greater risk for that because it's kind of given all your receptors a chance to be quiet for at least a month, because it's a monthly injection. And that if you don't come back and get your shot, you're much more at risk. We haven't seen data to really support that now that it's moved out and there's more people getting it as a treatment for opioid use disorder, but it still is on the warning and paper inserts that you get with it. It's still a warning, and we always tell our patients that they know they're going to be that's true when they drop off of buprenorphine as well. So it's an important fact. But the other thing is you cannot use an opiate for pain if you're on Vivitrol. It just blocks the effect. So that if you get hit by a truck, you need to be in, and you had to have surgery or need to have pain meds, it needs to be done very cautiously and usually in a supervised, structured environment like a hospital. But it can be done. So I tell my patients, if they want to be on Vivitrol, don't worry about being hit by a truck. I mean, don't get out there and try to get hit by a truck. But if you do, your doctor will be able to take care of you. Just make sure you tell them you're on it. I mean, there's ways of doing it, and people survive without any trouble. So these are really the 3 medications that the FDA has given us, and the 3 things that are the underpinning. Do these things really work, and what actually works? This graph looks at the number of relapses per 100 months of treatment. Strange way of measuring things, but that's what they measure. So the point is that the higher is worse. The higher is not good on this graph. So you've got many more relapses, and this is from your non-opioid or just behavioral treatment alone over time, and this is 3 years, than you do if you're using some kind of medication. So behavioral treatment alone in the treatment of opioid use disorder isn't as effective. You're much more likely to relapse, and right now we know that it only takes 1 relapse for someone to be dead. So I think that's part of why we are pushing the notion that people need to be on medications in addition to getting behavioral treatment, because it's not been shown to be effective, and because we know that people are dying when they relapse. So we have decades of good data on methadone maintenance. I'm not going to make you listen to me go through all of these. Just trust me. Just look at the number. Look at this. This has been going on since the early 90s. It's everything from decreased crime to retention. People stay in treatment longer, and they don't convert to HIV as much, and they get employed, have health and social functioning. Not everybody that uses methadone is standing outside the methadone clinic trying to cop benzos. They're the ones you see when you drive by there. They're the ones that give the place a bad name. But when you look at the individuals on Robin's roster that are getting take-homes, that are going to work every day, that tell me this drug saved my life, it's significant. You just don't hear about them as much. So methadone is a very valuable treatment, and it needs to be held up as one of the options, because even though it's stigmatized and people say, well, I don't want to do it, sometimes it's the only thing that works. And if it works for the individual, they should take it, because it's going to save their life, as opposed to worrying about the stigma. I tell people, if they go there and they do their job, they'll be getting take-homes relatively soon. And if you go there and do your job, your take-homes increase over time. So it's a very effective and useful treatment. The other one, which I know a lot more about, because frankly, methadone has to be given in a methadone clinic, and I honestly haven't worked in one for 30 years, but I used to. So that now I am much more familiar with buprenorphine, or known in the community as Suboxone. It's a medication that I can prescribe in my office. It's a medication that came available to us in the early 2000s with a piece of legislation called Data 2000. And this study was one of the things that pushed the legislature and everybody to look at methadone, look at buprenorphine as a real maintenance treatment. When it first came out, people were being encouraged to use it as a detox agent and to detox people and to step them off of their drug of choice onto behavioral health. And so they started looking at doing it, and we actually have 1 or 2 providers in this community that still have mandatory detoxes at month 6. And there's no data to support that that's good practice. But what we did learn was that when we gave people a 2-week taper, or a 6-day taper, we looked at whether they actually remained this is remaining in treatment, and this is over time, people that got the taper, which are the squares, didn't remain in treatment, and 4 deaths occurred out of a sample of 20 people. When you gave them the buprenorphine and you maintained it over time, you can see that there were no deaths, and that people really were retained in treatment at a much greater rate. It's hard to keep opiate-addicted people in treatment, period. So these numbers are not great. None of us have solved that. We still have people dropping out of treatment, even though we're trying. But if you just taper them, you know that you will lose them, and many of them will die. So it sort of gave us the underpinnings that we should not just use it as a detoxing agent, but consider doing maintenance. This study is hard to see and it's complicated. I put it up here just to drive home again a notion that this was a study that was done by Roger Weiss and the CTN, which we were part of the CTN, but we were not a site for this. It was a study to try to look at just prescription opiate abusers and the role of buprenorphine in its treatment. And because they're not supposedly as sick as the heroin users, could you maybe detox them? Could you take somebody who's got on a less potent opiate and give them a short-term detox and have them be able to do well? And so NIDA paid a lot of money for us to find out that if you give somebody a buprenorphine, you give them buprenorphine for 2 weeks, and then you taper them for 2 weeks. When you go back at 3 months, only 6% of those people are going to be opiate-free. We can't tell you which 6%. If I could, that would be perfect. We could say, you're in the 6% and you can be tapered off of heroin and you don't need to be on buprenorphine. Do the math. That's 94% of the people relapse by 3 months. So they put those people on another study, and these are all randomized. These people got randomized, and everybody is getting CBT. Everybody across the 12 weeks are getting behavioral treatment. It's not making a difference. They then put them back in, gave them an 8-week follow-up, and this time they basically gave them 3 months of buprenorphine, and then took them down and followed them out 3 months later, and only 8% were successful. Those 8% have been getting CBT the whole time. We just don't have good data that it can do it alone. That's all I'm saying. That if you don't maintain people, they relapse. So, but buprenorphine is not a perfect drug. It's not the end-all and be-all for everybody. I'm not saying that it doesn't have its own problems. We mentioned earlier that people divert. They sell their medication. They do. But there's a lot of good data that says that, and this was in this, that at least 33% of the people going into treatment in 2013 said that they had been using or have used diverted buprenorphine. There's good data to suggest that 90% of the diverted buprenorphine is being given or to friends or sold to people they know in order to prevent withdrawal. There are very few people getting diverted buprenorphine who are getting high. It just isn't happening. Everybody's tolerant. They're using it to prevent withdrawal. Guess what? They're not using a needle. They're not putting a needle in their arm. They're not risking an overdose with fentanyl. Do I go home at night and worry about, oh God, I wonder how many of my patients diverted today? No. Do I talk to them and tell them not to do it? Yes. Do I count their films every time they come in my office? Yes. Do I count their pills? Do I look at the PMP? Do I do everything I can to keep them from diverting? Yes. But does it bother me? No. Because I know that most of the time, most, if not all of the time, people are just selling it to, the people are using it to keep themselves from getting sick. We are more and more finding people coming into our program who are on street buprenorphine, have been buying it on the street for 2 years, realize they're foolish, realize they live in a state that they can get insurance for, and they can get it paid for, and they can stop spending that money on street buprenorphine and buy themselves a nice hamburger at McDonald's or whatever they want. They finally did the math and figured out that they wanted to give up that aspect of a drug addiction, which is being on the street, having to constantly buy something, needing to know where their next buprenorphine was going to come from, and that their treatment needed to begin to be able to give up those behaviors. So we're seeing more and more people come in. People do try to bridge between different types of illicit use, and that's just sort of the people that are bridging themselves or trying not to get sick. And we do know that it's very hard for people to remember to take something every day. How many of you have gotten antibiotics for a 7-day course of any antibiotic? Most of us in our lives as adults, if we haven't by now, it's unusual. I'm going to see you after the talk. How many of you finished all 7? Very few. If it's a 10-day course, do you think you could finish 10? It drops off. And if it's something you have to do every day, day in, day out, adherence for any medication is poor. Adherence in this medication is somewhat higher because if they don't take it, they do have symptoms of withdrawal, but it's still, adherence is a problem. And we find that when people start missing doses, if it really drops below about 80% adherence, which is sort of the standard adherence for, that'd be high for any other medication, rather not standard but high, that then their relapse rates go up. And we do know that there are accidental poisonings in children. And all of that stuff that I told you about buprenorphine not making you go to sleep and not wake up or die of respiratory distress isn't true if you're a kid. For our kids, buprenorphine can be lethal at small doses. And so it's very, very important that if your child or someone is exposed to even a small amount of a Suboxone film, they need to be monitored. So the other issue is, with medication that we mentioned, is extended release naltrexone or Vivitrol. Now this is the newest kid on the block. It was approved for us in 2010. How many of you have patients that are on Vivitrol? That's a good number. If in various parts of the country, if you'd ask that question, nobody would raise their hand. If you travel to Boston, very few people will raise their hand. It's a medication that hasn't really been able to find a market yet, but it is increasing in market share since 2010, and more people are requesting it. But it's an injection that has to go into your gluteal muscle, meaning the muscle of your butt, and you have to go into the muscle, not the fat, in order not to have a reaction. It comes prepackaged and has to be refrigerated, and you have to reconstitute it before you give it. And the person must be opioid free, because if they're not opiate free at the time you give it, it will precipitate withdrawal. And it can precipitate a pretty nasty withdrawal that has actually resulted in some people having to go to the hospital and be admitted. Doesn't happen often, but it can happen. More and more people are trying to shorten the window of the 7 days, the 14 days that I spoke to you about. More and more treaters and more patients are trying to shorten that window. And I was at a meeting on Friday, and I heard this person talk about giving it at 2 days after their last opiate use, because the patient knew they were going to go back out and use street heroin. And the patient wanted it and said, I'll be sick for a day. Give me clonidine, give me lorazepam, give me this, for Requip, give me all the medicines we need for detox, but give me the shot. And there are more and more people doing that. I haven't done that yet, and I don't condone it. We still are trying to, have people wait the 7 days and pass what we call a little naloxone challenge test to make sure they don't have it. But I think if you determine that you need Vivitrol and you really want it, it's a tough drug to get on, and people are sometimes just biting the bullet saying, give me Zofran. I'll deal with the nausea, I'll deal with the pain, I'll deal with everything for a day, because I know then I will be protected for the next 30 days, and if you keep your shots up every 30 days, you don't go into withdrawal. And you don't crave opiates. And if you happen to slip up and use, you don't feel the effect of them. So it's a good drug to have on board, it's just getting it on board. So what do we know about which one of these medicines is better than the other? I just told you about 3 things. How do I choose? And how do I know which medicine's going to work with which person? Guess what? I don't. I tell my staff, the best medicine for that person is the medicine that they want. because that's the medication they're going to take. So if they come to me and they say, I want methadone, I say, great, let me show you how to sign up for it. I want buprenorphine, let me tell you what we need to do. I want Vivitrol, let me tell you what we need to do. I don't try to talk people out of one and into another. And you will find over the course of most people's addiction, they will probably go through 1 to 3 of these, or might circle back around. And at different points in their life struggle, one medicine's going to be right for them and one's not, and another isn't. And our job is to sit with them, talk to them about what their options are, and try to find out which one works best for them and their lives and what they're willing to do. Not everybody thinks like me, though. And I do know that there are people who are, I sat with them that are zealots. They only believe in methadone. There are other zealots that say, I would never prescribe buprenorphine. I've been to national meetings with pretty famous addiction people say, I do not have a waiver. I would never give opiates to any of my patients. They just not using it. They don't do it. They don't believe in it. They only believe in Vivitrol or AA and NA and working the big book. And that works for, that's their practice. But the data that I've shown you today would be that we need to try to get more people on something, and we need to be open to it, and it would be nice to know if one is better than the other. So the, you haven't given me any sign.
I gave you the 20 minutes.
Oh, did you? I didn't see it. I got it, but after 20 minutes.
It's 20 minutes now, Dr. Miller.
Okay.
It's 15 minutes.
I'm going as fast as I can, but I'm thinking I got it. But anyway, so the National Center for Drug Addiction wanted to help us try to get some information about what's better than the other. And so they funded a study that we were actually part of. So I'm going to brag about it a little bit because we were one of 8 sites that participated in the study across the nation. And you don't need to read the slide. The slide is just here for me so that I can remember that we screened 700 people and we enrolled and randomized 550. So this is a large study. Several people helped me with it or here in the room. It's euphemistically called XBOT. And so from here on out, it looked at trying to compare in a randomized controlled trial, trying to compare extended release naltrexone or Vivitrol to sublingual buprenorphine or Suboxone film. So it's a comparison study. So it's what we call a head-to-head. There are very few of them around because they cost money and most drug companies don't ever want to pay for them. But the government paid for this one. And what we found was that when you look at getting people after they are randomized into taking a medication, and this was just 1 dose, it was very easy to get people on the buprenorphine. About 94% of the people that got randomized got the drug, but only 72% of the people got the Vivitrol. Just demonstrating the difficulty that I spoke to you about earlier. That it's very hard to get people to stay in detox long enough to get opiate free. It's impossible, near impossible to do it as an outpatient. And so the people that got randomized to that shot didn't always get it. But if they did, and this side over here talks about those people that got, everybody that got medicine, if you look at it, it proves these numbers would demonstrate this. There's significantly, buprenorphine is more effective than Vivitrol. But if you look at everybody who got the drug, and you take away this hurdle of induction, the drugs perform essentially the same, and the significance falls out. So what that means is, when I sit with a patient now, I can tell them that I have 3 choices, but that I do have a pretty good randomized controlled trial that will show that if they choose to go on either one, they can be, and we can get them onto either one, that they'll be equally effective. So that's big news, and that only happened last year. That's when Nancy talks about the Lancet article, that's the Lancet article that we published. It just showed overall that it's very hard, we knew, to get on the buprenorphine, and that essentially they're the same. And neither one of those medications, I didn't show you the slide, but neither one of them appeared to have any increased deaths, and they both appeared to reduce the overall overdose risk compared to the general population. The other medication, and this is where the idea of knowing that the word buprenorphine means a medication, the other thing that's happening is people are trying to branch out and get more and different delivery systems for these medications. And this is implantable buprenorphine. This is a little, you can see that this is about the size of a toothpick, and it is what we call an implant, or probufene, or buprenorphine implant. We help study this drug, and each one of those little rods has 80 milligrams of buprenorphine. Those get inserted into your forearm, and they give you a controlled amount of buprenorphine for 6 months. It's been approved for the use of individuals who are taking 8 or less milligrams of buprenorphine. So it's usually being employed by people that had a low tolerance or are at the end of treatment and have tapered themselves down. But it will last you 6 months. It has to be removed. It's a minor surgical procedure, and you can get it reinstated in your other arm. We have data on people up to 4 different insertions or 2 years, 24 months. And all of the safety data would suggest that it's extremely safe. And no one has gouged it out and melted it and injected it. It's a whole lot easier to buy it on the street. So it's a very safe way of administering the medications. It was approved in 2016, and we have about 300, we have data on 346 people. As I say, it's basically all of it very safe. It hasn't found a real market here anywhere. It's has struggled because of the price. It's struggled because it's difficult to get it delivered to you from a pharmacy that you have to beg for, and you have to be able to call on the right day at the right time and get the right person. It's just been a lot of hurdles. But the medication itself, in theory, is very effective and useful, and no one can divert it. You know the person has it. The other thing that's coming down the pike now that was just actually approved this year is injectable buprenorphine. Injectable meaning you need to get a shot once a month for this product, just like the Vivitrol. So it's a 30-day supply. And this was used euphemistically RB6000, but the company gave it the name Sublocade. You may have seen it. Let me guarantee you, if you haven't heard from it, you will soon. This company will have advertisements on the TV very soon for Sublocade, because they're launching the product very aggressively. This one, you get injected into your abdomen by a healthcare provider. You can't do it at home, not like your insulin yet. It's in abdominal into the fatty tissue, and you need to get, as I said, an injection once a month. You're either going to get 100 milligrams or 300 milligrams. That's all you're going to get. They only make them 2 sizes. You start, they recommend, everybody starts with everyone has to be put on the sublingual buprenorphine for a short period of time, anywhere from 3 to 14 days, but you have to be on the oral. Then you go in and get your first shot. The company's recommending 300 milligram shots, followed by maintenance of 100. Let me tell you, we did this study too. The first day we put 300 milligrams of buprenorphine in someone's tummy, I was a pretty scared woman. I was not sure, and the company was very rigorous with safety, and these people were hooked up to EKGs, and they wore a Holter monitor for 24 hours, and we watched them every minute for the first 5 minutes, and then every 15 for an hour, and then every hour for 5 or 6 hours that people sat with us. We knew them well. They were in the office the full day their first time. But they did fine. They did fine. There were a few people that felt sedated the next day, and if you look at across the study data that they have, there was not enough to really register as an adverse event. It was a study that was randomized in which people were receiving the medication or placebo. So some people were getting placebo shots. And guess what? If you get 300 milligrams of buprenorphine in your body, you're going to have fewer positive urines for illicit opiates than you do if you get placebo. That's all they had to prove to get it approved by the government. But now I'm being facetious, because it's buried in that, which was thousands of shots, was a lot of safety data, a lot of EKGs. I mean, 44,000 EKGs or something like that was done in the study. Effort was made to make really sure that it was safe and there were no big issues with safety. So it certainly, the darker areas showed people having 80 to 100% of weeks with no use. You can clearly see that the medication was much better than the placebo. And that this improvement with no relapse was sustained for 6 months. And I was going to say, so those are the numbers. They enrolled 400 in 300, 400. Yeah, so we had about 500 people in that study. The other medication that is under review and that the FDA is supposed to make a decision about by December is a medication that's known as CAM 2038. We also did that study here. It's another much smaller company and a much different system. You can see CAM, if you just look at this is a very tiny needle. The other one was a 19-gauge needle, for those of you in the office, in the audience that are nurses and know what gauges are. That's a big needle. This is a 23-gauge needle. This can be given in various injection sites across your body, which are much more standard, like arms, buttocks, thigh. You know, they pretty much can go anywhere. And it is, like everything else, supposedly, you know, we will have no one abusing it because or misusing it, and we'll know what their dose is. But the big difference here is that there are various doses. And CAM, when it gets approved, will have a weekly shot and will have a monthly shot. And they are correlated much more with daily sublingual dosing. So we're all hoping that this will come about and that we'll have it. And this was a paper that sort of was just published in May talking about these weekly monthlies, and we've got our fingers crossed. This is just the graph that shows that this study was a head-to-head with these injectable versus the sublingual, not placebo. And when you do that, this purple line illustrates the number of opioid-free weeks. And it doesn't look significant, but it's the area under the curve. And it's a distribution, and it's a complicated way that FDA likes to see it. But just trust me, that graph shows that the medication was more effective than the sublingual. What's next? We don't know. There are other products that are being developed. There's lots of effort to add support situations like phones, like computer-based learning, like text messaging, like things that you can enhance any of these treatments with, but we don't know. So that's all that I have. All of us would be glad to answer any questions. We were thinking that if we had time, we would just open it up to any of us or any questions that from any of the presentations this morning. Yes, I know it's Doris. She's waving at me. I'm sorry, I can't hear you.
Going back to the beginning when you said Dr. Weiss's study, where he was taking
Yes.
people and decreasing their liquid, did they start out with specific milligrams of
No, those were, well, it was people were on basically average around 16, but they were medicated to the point that you would consider a clinical response, meaning it wasn't just a taper like we do in detox. You know, because that's what you're asking. It wasn't like the prescribed withdrawal program. People were given buprenorphine for 2 weeks and then tapered, and from whatever dose they were on. Any other questions? Yes, sir.
Dr. Bailey, you showed that if you had a full agonist that changed the brain with scans, you can see demonstrable changes. Does buprenorphine do that?
Yes, those scans were from people who had been using cocaine, and they've been abusing cocaine. There are scans of people's brains while they're using buprenorphine, and we can illustrate sort of a notion of what milligram you need based on how many receptors are still open. But we don't have scans, I haven't seen scans that show the opiate inactivity. I mean, the thought, I think, is that cocaine acts a little differently. It's not acting on the mu receptor. is acting at the site of where the two nerve cells meet to cause an increased release of dopamine there. It's not sitting on a receptor in the same way. And I think there's some thought that it's more damaging to the connections. And that's why those scans are so impressive. Yes, ma'am?
So a challenge I've seen on buprenorphine is that people say, I don't want to be addicted to something else. So is there a way to get around that?
So what you're asking me is, why aren't you, I'll try not to quote our great political leaders, but the notion that you're just substituting one thing for the other and you're still addicted. Okay. So I do think that that's a really reasonable question, but I think, let's think about it, what it means to be addicted. How do you define addiction? We talked about it being a brain disease, but what characterizes the activity of somebody who has an addiction? The four C's, really, right? Consequences, that you're using in spite of the fact that there are serious consequences, that you have severe cravings and the need to increase it's intolerable cravings to find the drug. What are the other two? I'm sorry? Continued use in spite of the consequences. Compulsion to use, consequences to use, and I shouldn't bring this up if I can't say them, right? But the point is that an addiction is a composite of not only what we know is going on in the brain, but the behaviors that get brought about as a result of that. So that you engage in illegal activity, you engage in poor decision making, you constantly crave the drug, you have to have it, it's what you think about when you get up in the morning. And that, that's all of them, I guess, but and that you do have a tolerance, and that you therefore need more in order to get the effect. If you look at individuals who are taking buprenorphine as prescribed, those behaviors don't exist. They have tolerance. Yes, their brain has the medication there. They're sitting on the mu receptor. If they stop it, they will get sick. Same thing would happen if they were taking clonidine for high blood pressure. There are a lot of drugs that we take that we have tolerance to, that we have to wean ourselves on and off of. But when it's working well, my patients are not craving drugs. They don't get up in the morning and think, what am I going to do to get my next hit? They think, let me see, I need to brush my teeth before I have breakfast or after I have breakfast, and now I'm going to a job where I can think about what I'm doing. Their behaviors, they're no longer participating in criminal activity. They're no longer seeking out the money to buy, or not getting, so their whole brain is allowed to shift away from being addicted, even though it is tolerant, into being a person that can function and make choices to rebuild their life. And I think that's really the hope, is that while the medicine is in their brain, that they have access to rebuilding the behaviors, rebuilding the bridges to those relationships that they burned, to those jobs they lost, and to the education they never got. Whatever it is that they need to restore can happen while they're on the medication, and that doesn't happen when you're addicted. So that's the real difference. Is I think, yes, people are tolerant, they do have an opiate in their system, but they do not behave like people who are addicted. If they are medicated, if it works for them and they're being medicated correctly. And we know that the longer you stay in treatment, what we were saying before is that we need time, people need time to redo those things and to rebuild that life structure and to have consequences that would be, that they want to live for, not to relapse for. And so if we keep them in treatment, they're much more likely to be alive to be able to gain that. Yes, sir?
People dropping out.
Yes, sir.
No one has mentioned, how does the insurance payment system kind of enter into this? It used to be insurance ran out. And you get discharged, especially a private facility, you'd be suddenly like discharged and you were cured. Does that enter into any of this information?
Well, some of you that deal with insurances more directly might know, but I think the first part of your question is about retention, and I think it's an absolutely important question. And I kid with people and say, if I could figure out how to keep people in treatment, I could get a Nobel Prize, because nobody knows the answer to that. If you look at all the data that looks at methadone and buprenorphine, and we don't have enough data yet on Vivitrol, there's a large number, about 30% of the people they just drop off at 3 months. And by 6 months, you've got another 20 to 30% that just don't come back. And those numbers I showed you, not very many people were treated and doing well and didn't relapse if they were out of treatment by 6 months. People who do well are people that stay in treatment and stay in treatment for longer periods of time. So I know that they're dropping out of treatment not because they're well or not because they're cured or not because it's going to be a good outcome. So we haven't figured out if there are brain changes that really get reset, or there are ways in which something happens at 3 months, whether it's psychological too. They've not been high for 3 months. They've had a chance to assess the landscape. They see the wreck their life is in. They're now facing lots and lots of challenges. They don't have good stress tolerance. They're trying not to relapse, but they're faced with, now I want to get a job, but I don't have any skills. And a lot of those things drive people back to the need to have a medication to help them deal with stressors. So there's psychological issues that happen in the first 6 months, but I think they're chemical things. It's so classic. So how we can keep them in treatment, I don't know. But it's really not anymore. It's not that the insurance company tells me I have to discharge somebody at 3 months. I might have to beg if I want to get somebody on higher than 16 milligrams. And after 6 years of using methadone, buprenorphine or something, sometimes they want to know why I don't make them go to group every week still. But, I mean, it hasn't been a deterrent in effect that they force me to discharge people. There are states where that happens. There are states where people only get like 6 months of treatment, or they only get 1 year treatment and they're done. I mean, there are states that aren't as up on the data and don't understand the role of the disease as a chronic relapsing disease. But luckily, we live in a state where they do. That's right.
Yeah. So in relation to the benzodiazepines and then the other co-occurring disorders, right. Can you just talk a little bit about how that plays into the MAT process in terms of monitoring or other outcomes with that, with the management?
Well, and I guess if Sue has anything she can add too, but as far as the MAT piece is concerned, it's been a challenge because there was one study that came out of France that showed early in the buprenorphine history that they had some overdose deaths when benzodiazepines were used with buprenorphine. They were using pure buprenorphine, but be that as it may. Those people were injecting clonazepam and Valium. So they were injecting high-dose benzos, and they died. Because just as I said, you know, the buprenorphine levels off the respiratory depression, but if you put alcohol on there or you put benzos on there, you can still die. So that led to a lot of worry about benzos, and it led to black boxes by the FDA, which is a special kind of worry warning, and it's led to a lot of people being scared to death to use them. And we have over time, and I have over time, have sort of mollified and wrung our hands, and we try very hard to have people not take benzos, but we sometimes do allow it now. And we try to have certain milligrams so that they're not taking 8 milligrams of Xanax a day, for instance. We try to set some limits, and I guess the methadone clinic does the same thing. People that are abusing benzos, we work very hard to get those people to not do that or to get themselves on Vivitrol, because at that point, they're taking a medicine that won't it will be complementary to or interactive with. So we try to offer that to people that insist on abusing benzos as opposed to just discharging them, for instance, which is what we used to do. We used to say if you were using benzos, you were discharged. Now we say this isn't working and you're doing something very dangerous, and I don't like prescribing things that were dangerous. Let's see if we can come up with a less toxic treatment plan. But
So,
I do.
can I just give
Yeah.
I can tell you in the NAPCO room, there is a
Use the mic.
benzodiazepine.
I can't hear you from
I was going to say, in the methadone program, we do have a benzodiazepine policy. So like Dr. Daly referenced to, there's a certain amount of milligrams that you can be on depending on what benzodiazepine that you're taking. You can only be on one particular benzodiazepine, so you can't be on two at the same time. They monitor it very closely, so through urine screens for illicit benzo use, and if folks do come up with illicit benzo use, they do reduce their dose. So they're a little bit more cautious because again, if someone's using illicit, we don't know how much they're using, how often they're using. And we will again work with them as far as doing the behavioral help portion of it as well, finding out why they're using. If it's a legitimate need for that use, if there's a co-occurring disorder, then we try to get them into treatment with the provider so that they can get that, so it's monitored.
And sorry, and then if the Vivitrol is an antagonist for benzos as well?
No, it's not. It's not an antagonist for benzos. It just means that they don't have an opiate in their system. So they're not. It's not an additive. It's not 2 + 2 = 6. It's just 2 + 2 = 4. It's not additive. If you've got an opiate and you add a benzo, you've got much more respiratory depression. I mean, and this is where I think that these are the challenging people. These are the polysubstance abusers are the people that, those are the people I go home and worry about at night. Those are the challenging people. But I keep telling my staff, this is what we do. This is substance abuse treatment. And this is why we need behavioral treatments, because somebody needs to sit that person and find out what's going on that they need to be so zoned out on benzos all the time. Is it the past abuse? Is it the current abuse? Is it shame? Is it guilt? Is it just panic attacks that they've had since they were in the Army? I mean, I don't know. But that's where a good behavioral therapist, a good mental health provider is very helpful and necessary so that the person can stay safely on the buprenorphine and that we can treat the substance abuse disorder. People use lots of substances. We just have to get used to it. But it's harder because some people just like to be numb. And we don't have, there's no pill that's going to take that away. But yet, I do think there are some behavioral health therapies and some treatments that can help people who want to just be numb. But, they're not instant cures.